So let's get started with today's clinical topic. And our speaker today is Dr. Maryam Ekhtiar-Kord. She is a private practitioner with offices here in Orange County and Mission Viejo and Newport Beach. She received her dental degree from the wonderful Baylor College of Dentistry, and she has a special interest in cosmetic dentistry and is a member of the AACD. Her presentation today is about minimally invasive restorative dentistry and some of the protocols that she uses to conserve tooth structure. So I am delighted to turn this over to you, Dr. Maryam Ekhtiar-Kord. It's all yours.
Thank you, Dr. Park. Thank you, everyone at GlidedWell, for having me. It is truly an honor and a privilege to be here to speak about one of my favorite topics in dentistry, and that is minimally invasive dentistry using CAD/CAM technology. And I will share my screen with you. So here we have minimally invasive dentistry with our learning objectives. We want to describe how conservative tooth preparations can lead to better restorations and long-term tooth health. Review the benefits of CAD/CAM technology regarding microleakage and sensitivity. Identify techniques and parameters utilized to preserve more natural tooth structure. Learn about material selection using a ceramic-filled nanohybrid resin. Discuss cementation protocols for onlays and inlays, and also briefly touch upon practice growth opportunities with CAD/CAM design systems. Before continuing, I just want to disclose that I am not sponsored by any company, and everything that I discuss today is of my own choosing and liking. So my digital dentistry journey. This is my office staff. This picture is about 9 months old. And the staff had some concerns with intraoral scanning as well as in-office milling. Of course, I don't blame them. They were tech shy with CAD/CAM designs, and they didn't have experience with digital scanners or any in-office milling system. I chose to go with the GlidedWell Fast Mill, and in the height of the pandemic in 2020, the GlidedWell team came to my office for 2 full days, and they trained my staff thoroughly. In addition to that, in 2021, I had additional training myself at the GlidedWell Educational Center. So the scanner I chose was the iTero scanner. My first scanner was in 2018, and subsequently I upgraded to the iTero 5D. What I love about my iTero scanner is that it integrates beautifully, perfectly with my GlidedWell Fast Mill. With that, I can have wonderful same-day restorations, and basically, depending on the restoration, it can be even under 10 minutes. This is a close-up of the area that I have my fast mill. And as you can see, the fast mill doesn't have any external water source. And it's relatively small compared to the monitor. So what are the benefits of intraoral scanning and in-office milling? Well, the intraoral scanning compared to traditional PVS impressions, the time it took me to take a traditional impression was anywhere from 3 minimum to 7 minutes. And intraoral scanning is much faster. and you're able to view the impression on a monitor. The nice part is that if you need to do any type of adjustment, you can do it on the spot and you get a better quality of impression, of course, which leads to a better restoration. This is a number 14 inlay. My assistant David is scanning our patient. And what happened was that we had hemostasis issues. So we went back and actually rescanned the area. And I want to just quickly thank Dr. Patricia Torres at Align, as well as Adam, my rep, for creating this video for me. From there, our scan goes to our fast design software, where I mark the margins. Now, this is not the previous inlay, of course. This is a bridge prep that I did, but you can see how easy it is to quickly mark the margins. And from there, the AI rendering of the restoration is absolutely phenomenal. It is 90 to 95% accurate. And in addition to that, I call in for additional support with the GlideWell tech team. And they dedicate anywhere from 5 to 10 minutes per unit. It depends on the case, and we get a wonderful restoration. So digital dentistry, participation in it for me, I love it because it allows me to engage in both the right creative hemisphere as well as the left analytical and scientific hemisphere of our brain. As dentists, we do this on a daily basis. And when you see your prep on a large monitor, it is a very humbling experience. You can see all of the undercuts and every little detail. And I feel that the digital dentistry and being able to see it on the fast mill, the fast design software in particular, it has made me a much better dentist. And what I want you to do is to view this through an educational lens, because it truly allows you to grow as a dentist and be a better practitioner. So patient benefits of intraoral scanning include increased comfort and a better patient experience. You don't need the gooey, sticky impression materials that we used to use, and the accuracy and precision is much better. In addition to that, scanners, intraoral scanners, allow dentists as well as our staff to communicate treatment plans using digital images. When a patient sees a visual representation, they're better equipped to understand their treatment and all of their oral needs. These are images from my iTero scanner, and it allows the patient to see various dimensions of their occlusion, different aspects, the amount of bruxism and pressure that they place on their teeth, and it just allows for better communication and understanding. So one thing that I absolutely love about having a digital scanner and my fast mill is that it has truly reduced the amount of storage space. I have a small boutique practice, and I no longer have to store a bunch of impressions, stone model pour-ups, and not to mention that it aligns with environmentally conscious practices, and you can easily retrieve and reference a patient's record digitally and access and share that with specialists if need be. So the digital workflow integration is seamless from my scanner into the Glidewell IO software. And as I want to mention in a moment, the turnaround time is phenomenal. With the Glidewell Fast Mill, you can mill a Bruxer now anywhere from 35, 40 to 55 minutes, Bruxer Aesthetic, half an hour to 45 minutes, Biotemp as well as Camouflage now under 10 minutes, and Obsidian as well. And this is the inside of my drawer where I keep all my milling blocks. And as you can see on the far left, there aren't any more camouflage left. So it is an absolute favorite in my practice. The Camouflage now is a fully cured ceramic filled nanohybrid resin composite material. I use it for both anterior and posterior indirect restorations. I fabricated inlays, onlays, veneers, and crowns with the Camouflage Now CAD/CAM milling block. I love that it is ceramic filled, and it really is a strong material. Biomimetic dentistry. What is it and how does it relate to Camouflage Now? Biomimetic dentistry. The term biomimetic is derived from the Greek words bios, which means life, and mimesis, which means imitation. Biomimetic dentistry, it's a minimally invasive approach to restorative dentistry that really seeks the natural structure and function of teeth. If we were to take a deeper dive into biomimetic dentistry, the goals are that we want to preserve as much natural tooth structure as possible. When we do this, we achieve long-lasting, functional, and pleasing results. And biomimetic dentistry, the principles rely on advanced adhesive bonding techniques. And these bonding techniques enhance strength of the restoration, and it seals the tooth. This also minimizes the risk of sensitivity and recurrent decay. What I love is that Camouflage Now is perfectly in line with this minimally invasive biomimetic dentistry approach. So why choose Camouflage Now over ceramics and glass ceramics? Ceramic reinforced resin composite milling blocks have the following advantages. It mills in under 10 minutes with my Fast Mill IO. There's minimal burr wear. And the best part is you do not need an oven. There is an absolute absence of heat treatment after milling. The polishing is superb. You can polish both extraorally as well as intraorally. It is amenable intraorally with light cured nanohybrid resin composites, and the edge stability is great. There isn't any chipping during milling and subsequent procedures, and there's low wear to opposing dentition. I really love this about the product. I've been using it for 3 years now, and I've seen it with my own eyes, even in cases of bruxism. And it has a very high rate of survival with minimal fracturing. So my personal preference for Camouflage Now. Honestly, I've had negative prior experiences with lithium disilicate restorations. There have been interproximal marginal gaps, which have led to microleakage and recurrent caries. The margins are bulky and difficult to adjust. And well, let's be honest, the cost of milling, the milling machines, it was something that was out of my budget. The margins are usually short, and that has led to post-operative sensitivity. And it wasn't cost efficient for the patient as well as myself. Another downfall was it has higher wear to opposing dentition compared to the ceramic reinforced resin composite, the Camouflage Now. One thing I want to mention, going back to bullet point number 3, the cost of the milling machine. The fast milling machine is truly affordable. And as dentists, for those of us who drive luxury cars, the fast mill is less than your luxury car, the price of it. So it has definitely been a wonderful investment for me. I want now for you to imagine yourself at work. You've had a very busy day of seeing several patients, and you think your day is almost over until this patient comes in. She's a 16-year-old female, a wrestling superstar who unfortunately had trauma to number 8 from a wrestling match. She's had a prior history of a composite from 2018 on tooth number 8 without any pulpal exposure. So I ask you, what is the best restoration and material? A composite or a crown? And what is the best way to approach treatment? Would you approach it with a PVS impression or with a CAD/CAM digital scanner and possibly an in-office mill? Well, in 2018 is when I first met her. She was only 10 at the time. And I must apologize for these photographs. They were taken with an iPhone. I think it was an iPhone 4. And it was our office iPhone. And I never thought that they would be shared on a webinar of all things. They were only supposed to be for her record, but never say never. And here we are today. A month ago, in December, she chipped the tooth again and only left a smidge of my composite from 2018. Closer observation reveals that number 9 as well as number 10 also have incisal-lingual chips, in addition to the class 4 fracture on number 8. To prep this case, I used a fine grit flat end tapered diamond. With my inlay and onlay preps, I usually start with a 557 and excavate with carries with a round burr, but that really wasn't necessary for this case. Instead, I went straight to the fine grit burrs, and there are 2 styles that I use, one with the red stripe and the other with the yellow stripe, which is a fine grit. So I finish all of my preps, may it be a posterior crown, an inlay onlay, or an anterior restoration, with a fine grit diamond. My favorite, the one of choice, is the flat end, because what that flat end allows is it prevents that J-shape curvature or curl at the margin, and that enhances a better juncture with the restoration. The benefits of a fine diamond finish is that it creates fewer cracks and trauma to the marginal enamel, and it also enhances bond strength that we want with our Camouflage Now through adhesive dentistry. So scan integration into the Glidewell Fast design. This is a screenshot of my iTero prescription. So it's very simple. You enter the patient's information and you select the type of procedure. From there, I chose to send it to my Glidewell Fast Mill. This is the image captured from our scan. And as you can see, the scan closely resembles reality. So once the scan is in our fast design software, I mark the margin and AI-assisted design creates a rendering of the restoration. In this case, I called in for tech support. And as you can see, the technician is designing the crown for the patient, and the design ranged anywhere, it usually ranges 5 to 10 minutes, and this really wasn't any different. So 8 minutes later, I have my restoration. So it takes about 2 minutes to scan at most, 5 minutes to create the crown design, the restoration design, and only 8 minutes to obtain your restoration through the fast mill. Here are different images of the case, the restoration, and as you can see, it has a very thin sprue, and the sprue is so delicate that you can just snap the restoration off just with light finger pressure. From there, I micro etch the intaglio surface of the restoration using 50 microns of aluminum oxide and my Danville micro etcher. For bonding, I isolate with Teflon tape and I use Ultra Etch by Ultradent. It's 35% phosphoric acid etchant. Glidewell CAD-CAM allows up to 37% acid etch. I've used Ultradent for years. It stays intact, and so I use it on this case as well. It appears that I did selective etching just to the enamel. I do want to tell you that I did do full etch of both dentin and enamel for 15 seconds. Apply just a medium scrub pressure, followed by rinsing with water. From there, I use Scotch Bond, 3M Scotch Bond Universal Plus adhesive. It has a 30-second application where you massage the adhesive into the dentinal tubules as well as the enamel, and then subsequently dry with HVE and light cure. Immediate dentinal sealing, it's very important that prior to, if you do not have a in-office milling, that you think about doing immediate dentinal sealing because it reduces post-operative sensitivity, it seals the exposed tubules, and it reduces the chance of microleakage. It also enhances bond strength between dentin and camouflage now and allows for better stability. I have better margin adaptations and reduced marginal gaps by doing this method. This is also in line with biomimetic dentistry principles. When I didn't have an in-office milling machine allowing me to deliver the restoration the same day, this was absolutely critical. And If in the event that you can't deliver the same day, this is really a key step to reduce sensitivity postoperatively. To continue with cementation, I use these wonderful micro sticks, but I have noticed they don't adhere as well to camouflage. So I have a little trick where I dab just a touch of 3M Scotch Bond adhesive onto my smallest micro brush, and I just hold it against the restoration at the edge. This can be done with something as delicate and slender as an inlay, all the way to a crown. Just light cure, tack cure under 5 seconds, and you can deliver the restoration to the patient. For cementation, for this case, I used 3M Filtex Supreme Flowable Composite. I have also used the RelyX Universal Resin Cement, also by 3M. So for cementation, you want to place the restoration on and wick the excess resin with the clean, dry micro brush. Follow it up with light curing for about 20 seconds with the Paradigm Deep Cure. So for adjustment and polishing, I initially used the 3M Soft Flex discs. I start with the coarse and subsequently move my way all the way to the fine disc. In addition, I really am a fan of the Shofu polishing system, in particular, the green fine and the pink super fine. It just provides a wonderful glossy look to the restoration. And I use that in addition to the 3M product. So the restorations that we placed were a Camouflage Now Shade 1 Low Translucency, because camouflage comes in both high as well as low translucency. In this case, I used low translucency, and I also placed composites on the incisal-lingual edges of both 9 and 10. And so there she is before, and here she is after. And she was very happy with the results. So with posterior inlays and onlays, I use Camouflage Now. And here we have a patient who has a very large leaking composite on tooth number 31. After caries excavation, we took a scan, and that's what this first scan shows. After scanning, I realized I'm not comfortable with having my restoration and the patient's enamel touch right at the juncture of the adjacent tooth number 30 at the distal lingual cusp. So the beauty of an intraoral scanning machine is that you can go back and rescan the patient, which is what I did. This is another case, a patient in his 70s with heavy bruxism. Initially, we didn't know that there was anything going on, but the radiograph revealed interproximal caries. After caries excavation, we needed to do marginal ridge elevation. The decay was very deep. So proximal box elevation, the procedure is where you bring the margin supragingival to an ideal level. We use composite to block out any undercut, and it allowed basing up to an ideal level. And the composite is also fully compatible with camouflage now. I deliberately left articulating paper marks on this patient to show you that his occlusion was completely off of the camouflage restoration. And as you can see, you can with a fine tip burr carve in tertiary anatomy into your camouflage restoration. For inlays, we have this case, patient tooth number 13. She has an MOD. And after removing the caries, I placed Ultradent retraction cord size 1, and I used Viscostat for hemostasis. From there, we took an intraoral scan using my iTero. And this is an image of just trying in the restoration prior to cementation. And you can see how close it looks to the fast design rendering of the restoration. And this is the final product after cementing and delivering the inlay. You can see the difference between the composite that she originally had and the camouflage now inlay. The amount of anatomy, it resembles a natural tooth, whereas the composite, you can tell that it is a restoration. And this has been my evolution in dentistry. And I want to thank you all for joining me and allowing me to share my journey with you.
Well, thank you, Dr. Cord. We appreciate that. And we've got some questions here. I think we might have some good discussion. The first question, this is interesting. So this doctor has had a scanner for over a year and is now considering to either get a milling machine or a 3D printer. How should he or she make this kind of decision?
Well, for me, my experience has been with the fast mill, and I can only speak on what I'm comfortable with and what I know. So,
I mean, for this doctor's decision-making process, it might be, uh, what does he want to do? What kind of products does he want to make in the office? So, in other words, if you want to print, then you can print models, you can print night guards, things like that. At this point, you're really not going to be printing restorations. So, if you want to do one-day dentistry, then really you're in the milling situation right now. Would you agree?
I absolutely agree. And for me, I wanted to place same day restorations, and the most important was to move away from the lithium disilicate restorations for the inlays and onlays. And that is the reason why I went with the fast mill, was because I wanted to provide under 10 minutes a restoration, which I do with the camouflage now.
Yeah,
And
I think it's really really nice that this doctor's kind of got into digital dentistry stepwise, right? Started scanning, is very comfortable with scanning, and now is going to move to the next step, which as you said, I think if he's interested in providing one day restorations, then that would be a mill. If there's other things that he wants to do, then you may be able to do that with printing. Right now, printing is a little more limited. There are some companies that are launching some printed crowns, but it's still in the very early stages. So, I mean, it's out there, but I think the milling obviously is very well proven over many years. Got a question on your case on that 16-year-old wrestler. Okay.
Yeah.
So, patient had a mesial incisal fracture, and one of the doctors wants to know why you didn't just go ahead and veneer that whole surface because you would have had more enamel for bonding rather than have the kind of margin that you created.
I still wanted, if you recall, she had a lot of enamel still. And because she's 16, I did not want to touch any enamel. At some point, she may need another restoration. There is wear and tear after all, it's not forever. But due to her age, I decided to preserve as much tooth structure as I could and therefore not touch the enamel today. 10 years from now, when she's 26, if I'm still in practice, I will modify the enamel and place the veneer. Absolutely.
Okay. So you were
But
being as conservative as you
as
possibly could be.
conservative as
Got
possible.
it. Got it. Okay. Lot of questions about the material camouflage that you talked about. So, first thing is shade. So, what shades does it come in? How do you select the shade?
Well, I like to have my own. I have an arsenal of shades, and as you saw with the boxes that I have A1 through A3, and there's high and low translucency. And the nice part is that you can easily, Dr. Park, are you there?
I'm here.
Okay, you can easily just take the milling block and place it against the patient's tooth. You really don't need a shade guide. You can do that then and there. And with the low translucency, it blends beautifully with composite.
You
So,
know, that's one thing I've noticed in our clinic because we do quite a few of these cases that it seems like it does sort of just take on the color of the nearby teeth. I don't know what the optical properties are that do that, but it does seem to match a lot better than most other materials, and maybe that's why they call it camouflage.
yes.
I've got a question here, and I should know the answer to this, and I don't. But do you know how thin camouflage can be milled?
I don't know how thin it can be milled. I do try to um, have it up to as thin as I've had it has been about a millimeter in depth, and
Okay.
that's based on the depth cut of a restoration. So how thin I would
But like on the marginal areas, how thin can it?
Oh, the beauty of it is that it blends, it can be very thin and it's flush against the margin. For
Okay,
instance,
so you can almost go to like a knife edge margin.
yes,
Okay. Okay. Good. Good. All right. Some questions about post-op sensitivity, and it sounds like this doctor's been having that as an issue. So first, his first question is the source from etching the dent in, or is it from micro leakage? You know, where does this post-op sensitivity come from?
I would always worry about excessive dentinal etching, but if you seal the dental tubules right away in line with biomimetic principles, you actually reduce post-operative sensitivity. And with the camouflage now, because it integrates so beautifully with nanohybrid composites, I haven't had many cases, if at all, of post-operative sensitivity. I did have them, however, with the lithium disilicate. So
Do you use any kind of desensitizing agent before you
I
etch and
have,
bond?
I have. One recommended product was Gluma. And I followed the recommended Glidewell protocol back in 2020 when I first obtained my mill to use Maxim by Kerr as well as Gluma. And that was very successful, but I'm very loyal to 3M, and I like Filtech composite as well as Scotch Bond. And I spoke with my 3M rep, and he stated that there is a desensitizer already present in Scotch Bond Universal Plus. So that eliminated the need for Gluma. But I definitely think that Gluma is a wonderful product that does reduce post-op sensitivity. I do use it for cases, not to digress much, but I do use it for cases where I mill my biotemps in office, and I send the patient home, and I won't see the patient for some time. I apply it to the prepped tooth, and then I cement my temporary, and the patient really doesn't complain of postoperative sensitivity.
Good,
Thanks.
good. For this doctor who's having this issue, would you suggest that he go ahead and use Gluma?
Absolutely, absolutely. I found it to be very beneficial.
Very good, very good. In your technique, do you take pre and post cementation X-rays?
I do take pre-X-rays, and we do take post-operative X-rays, yes. I always want to make sure that we don't leave anything behind. Always approach it with the dental school eye. So always want to take a post-operative X-ray, make sure there isn't anything there.
Good, good. Question about cementation again. Does the cam now restoration, does it need any kind of etching treatment itself before you bond it?
I used the micro etch.
Okay, you do use the micro
I
etch.
used the
Very good.
micro
Okay.
etch by Danville, 50 microns of aluminum oxide.
Okay. Can the .io milling blocks, can they be used for multiple inlays and onlays?
Oh, one block for
One
multiple?
block.
No,
Correct.
no.
No, it's a one. Yeah, it's a
One and
one shot
done.
deal.
One and
I mean,
done.
you could use one block for a 3 unit bridge, but separate restorations have to be milled separately, as far as I know. Okay. Um, Here's a question about using camouflage now for veneers and doing some staining on them. Uh, have you had experience with that?
I have, and I love that question. I, my practice is in Orange County, and staining is not something that is very popular among my patient population. So I have done it just to tinker around with the product
Yeah. Well,
uh,
you get the person that wants a veneer on one tooth, right? And then you
on the
have to.
one. And the beauty of it is that, yes, absolutely. To answer the question directly, yes, you can do that. It does allow you to.
Okay, I did get a message from our tech support people about the minimum thickness for camouflage, and it is 600 to 700 microns. Okay, so it
Wow.
it can definitely be milled pretty thin. Let's see what else. Uh, and there's some stuff there. You get some warnings on the software, and you have to ignore certain warnings. But you can go super thin with that stuff. So thank you to our tech support group. That was Ives that got back to me. And there's a question. Uh, is there any staining or glazing required on these camo restorations?
No, not at all. And that's what I love. You don't need additional equipment. You don't need an oven. There isn't any need to glaze it. It's pre-cured. It's a fully cured block. So there isn't any need for that.
Okay, and here's a great question. Um, how do you build this? Is this a ceramic or a resin?
Well, it depends on. I have patients with insurance. My practice does honor a lot of insurances, and it just comes down to what what the insurance allows and what the patient wants. A lot of it is patient education. If it's not covered, for instance, if an onlay or an inlay is not covered by the PPO, just have that conversation, just like Dr. Levin stated, have it up front and educate the patient on why this is a superior restoration compared to a composite. And then as far as billing, you can see if this is can be considered a 3/4 resin crown and submit that to insurance and see how it goes.
So we have had a lot of people opinions from insurance companies that have said that a highly filled resin, it's highly filled with ceramic, can be billed as a ceramic restoration. So that's something you want to check with the insurance company. What is the percentage? But in most cases, a product like camouflage will be considered a ceramic because of how highly filled the resin is.
And on with the X-ray, it's radio opaque. So if in the event that you need to submit additional records to an insurance, you do have that image.
Right, right. Um, okay, so any difference in using a resin cement versus a flowable composite as your cement?
I've tried both on numerous cases, and I I like the composite a little bit more. I do think that Rely X is wonderful. It's radio opaque and it fills the tiniest little marginal gap that you may have. But I find just basic Filtech universal composite, how I can handle it and manage it to be a little bit more, there's more ease to it than the Rely X cement.
Okay, so you're saying you use a fillable composite and not a regular cement, resin cement?
I have used both, but
So
in the
so what would your recommendation be?
I recommend both. It depends on the where it is in the mouth. If it's posterior, a resin-filled cement. And then
Okay,
if it's like our 16-year-old wrestler, I used a composite.
right,
And
right, gotcha. Right, got it. Okay, here's a general question about bonding dentin. When you put your dentin bonding material on and then you light cure it, doesn't that affect the seating of the restoration? Isn't there some bulk there that affects the seating?
no, because you want to always dry after you apply your bonding agent. I don't use a three-way syringe to dry the bonding off the tooth. The reason for that is I'm always worried about any type of contamination. So if you hold your high volume suction against the bonding agent, or use a clean, dry micro brush to wick away excess bonding agent, that serves as the best thinning method to get a better seal.
Great. Thank you so much, Dr. Ekhtiar-Kord. We really appreciate you taking the time and sharing your cases with us and your techniques and some of the things that you do in your office. We really appreciate that. And thanks to our panel for sharing their wisdom with us. And thanks to all of you for joining us today. Be sure to join us next week when our own panelist, Dr. David Hochberg, will be the lecturer, and he'll be talking about implant restoration, screw retained versus cemented. Be sure to join us, and we'll see everybody next week. Take care, everybody. Have a good week. Bye bye.